Primary biliary cirrhosis. Etiology, pathophysiology, and pathology. Primary biliary cirrhosis, PBC, is a disease of unknown etiology leading to progressive destruction of small intrahepatic bile ducts and eventually to liver cirrhosis and failure. It is thought to be immune-mediated as there is a predominantly T-cell infiltration in the liver. It is characterized by female predominance and serum autoantibodies to mitochondrial antigens, most typically targeting the E2 component of the pyruvate dehydrogenase complex, PDC-E2, that lies on the inner mitochondrial membrane. Possible etiological factors include failure of immune regulation, loss of tolerance, immune complex bile duct damage, and mitochondrial antibodies cross-reacting with bacteria. Epidemiology. Females account for 90% of cases and most present between the ages of 40 and 60 years. Prevalence is 25 per 100,000 in women greater than 18 years. Clinical presentation. Common. Asymptomatic, diagnosed as a result of investigation for abnormal liver function tests. Itching. Lethargy. Uncommon. Jaundice. Hematmesis, from varices. Abdominal distension, ascites. Confusion, hepatic encephalopathy. Hepatocellular carcinoma. Physical signs. Common. Initially none, subsequently pigmentation, xanthelasma, hepatomegaly, scratch marks. Uncommon. Late signs of portal hypertension, ascites and hepatic encephalopathy. Investigations. Liver biochemistry. High alkaline phosphatase and mild increase in alanine transaminase. Rising bilirubin is a marker of poor prognosis. Falling albumin and rising prothrombin time only occur at a very late stage in the disease as it is biliary cirrhosis. NB. The level of alkaline phosphatase does not correlate with the extent of liver disease. Insidious progression to cirrhosis may occur without significant changes in liver blood tests. Antimitochondrial antibody. This is present in 95% of cases and is specific for PBC. Individuals with antimitochondrial antibody, AMA, and normal liver histology will eventually develop PBC. Patients with AMA-negative biopsy-proven PBC, although rare, behave in the same clinical manner as AMA-positive patients. Antinuclear antibodies and/or smooth muscle antibodies are more frequently positive in AMA-negative PBC. NB. Non-E2 AMA positivity can be seen in syphilis, systemic lupus erythematosus and other autoimmune diseases. Immunoglobulins. IgM is often high. Liver biopsy. The histology is of lymphoid aggregates and granuloma in portal tracts, with bile duct damage and eventually bile duct loss. Progressive fibrosis results in biliary cirrhosis, Fig 40. Note, however, that liver biopsy is not essential to make the diagnosis of PBC in a patient who has high titer E2 AMA and typical symptoms and biochemical abnormalities. NB. In PBC the changes in the liver are focal, so a liver biopsy is not useful for staging liver disease. Furthermore, diagnosis does not usually require liver biopsy because of the specificity of AMA for this disease. Differential diagnosis. Large bile duct obstruction. Sclerosing cholangitis. Other causes of intrahepatic cholestasis, drugs, sepsis, total parenteral nutrition. Treatment. Short term. Ursodeoxycholic acid. Its role is controversial, but it appears to delay time to transplantation and death in late-stage disease. It may improve itching. Treatment at a dose of 10 to 15 mg/kg should be directed to symptomatic patients. Other immunosuppressives. Steroids, azathioprine, cyclosporin, and methotrexate have not convincingly been shown to be effective. Itching. Response to cholestyramine. If persistent, other drugs worth trying include rifampicin, benzodiazepines, ondansetron, serotonin antagonists, and naltrexone, opiate antagonist. Long-term. Liver transplantation. Patients who develop signs of decompensated liver disease or in whom bilirubin is greater than 100 mol/L should be referred to a liver unit if appropriate. Recurrence in hepatic grafts occurs, but this does not have an adverse effect on outcome in the first 5 to 10 years. Complications. Osteoporosis and portal hypertension are common in late disease. Osteomalacia and deficiencies of other fat-soluble vitamins are rare. Prognosis. Variable and unpredictable. Some asymptomatic patients may have a normal life expectancy. Symptoms generally develop within 2 to 7 years, with subsequent life expectancy varying from 2 to 10 years. Disease associations. Other autoimmune conditions, rheumatoid arthritis, Crest syndrome, calcinosis, Raynaud's disease, esophagus, hypomotility, sclerodactyly, telangiectasia, hypothyroidism, Sika syndrome, dry mouth and eyes, and celiac disease.